Hi everybody, again I'm Jess McCurley, and I'm here to share some results of a multi-level evaluation of the Massachusetts Medicaid Flexible Services program to address food and housing insecurity. Here are our disclosures and funding. So as many of you in the room here are well familiar with, health systems are increasingly developing partnerships, informal and formal, with what I will call in this presentation social service organizations or community-based organizations. I'll refer to them as SSOs, to address social needs like food and housing insecurity, right? And SSOs we know are critical because they have really important knowledge and expertise in their community's needs and the resources that are available. However, of all of these partnerships, a relatively small subset involve actual financial contracts for service provision, so health systems paying those community-based organizations, or SSOs, for that social care. And so best practices for implementation of these kinds of partnerships are really not known yet, and we need multi-level evaluations that hear from people on all sides of the partnership. So as has been previously mentioned, many states have been granted 1115 waivers to address social needs as of mid-January of 2025. As you can see in the blue states on the map, there were 22 states with already approved 1115 waivers to address social determinants of health, and a few more states with pending waivers in the green there. So Massachusetts has one of these waivers since 2018, and one part of that waiver is the Flexible Services program, which I'm going to describe here. So MassHealth, which is Massachusetts Medicaid, through the Flexible Services program, provides funding to accountable care organizations, or ACOs, in the state of Massachusetts, of which there are several, and Mass General Brigham, the home of this research project, is one of them. And those funds are provided to ACOs, health systems, to contract directly with social service organizations in the community that provide nutrition and housing supports. To be eligible for this program, individuals had to be, in addition to being enrolled in the accountable care organization, patients had to have demonstrated food or housing insecurity as seen on formal screeners or clinical interactions, and also a complex health condition, so something like diabetes or depression, hypertension, anxiety, obesity that was uncontrolled or had additional needs there. And amongst the suite of nutrition and housing services provided, nutrition services were provided by different organizations, but would be things like food boxes, produce gift cards for supermarkets, or medically tailored meals, depending on the patient's needs. And housing services were things like housing navigation or support applying for low income or low cost housing, and utility financial support. So to be clear, our research team was not involved in the design of flexible services or in its implementation. We are simply a team of researchers at an institution where we knew that this policy was getting rolled out, both in the state and in our institution. And so we applied for a grant to do kind of a more granular study of how this rolled out in our health system, particularly the implementation of it. And so this was one of the aims of our grant that I'm presenting on today. And the goal was to identify barriers and facilitators of successful implementation of flexible services and assess implementation outcomes in our health system using the REAIM PRISM framework, which is from implementation science. And participants in our study were adult Medicaid ACO enrollees and also staff at both the ACO, the health system, and SSOs, and that were partnered with the Mass General Brigham Health System in Boston. And this pilot ran from March 2020 to March 2023. You can see here, this is REAIM. Many of you may be familiar with it. REAIM stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. So constructs that are important to measure when you look at implementation of a new health service or a new program or a study intervention. And then above you can see the PRISM component, which these were published as a joint framework back in 2019. And the PRISM part refers to looking at specific internal and external contextual factors that can impact program implementation, and we were so glad that we proposed an implementation evaluation as part of our study of flexible services, because right as it was rolled out in early 2022, right, so the pandemic was hitting us, and so many of the planned methods for implementation and had to shift and change in that early time period. And so we were able to track and watch some of that as it rolled out. So we did a mixed methods evaluation with an explanatory design in which we collected some quantitative data about the program's reach and implementation, and then a host of qualitative data to help understand and contextualize what we saw in the quantitative data. Oops. Okay, going back to our quantitative data. So we looked at the enrollments, who was enrolled in flexible services, their demographics compared to overall ACO enrollees, and their qualifying health conditions through looking at electronic health records of about 96,000 adults enrolled in the ACO. And then our qualitative data, we looked at some of those contextual factors and then perceived effectiveness or impact, adoption, and implementation by doing layers of qualitative interviews. We spoke with patients who were enrolled in the Flex program and ACO staff and leaders and staff inside the SSOs. So delving into the quantitative data first, you can see here in the orange box that of about 16,000 ACO members who were eligible for Flex, about 2,500 or 15% were enrolled. Now, this was not designed as an entitlement benefit. It was just extra funding to support food and housing needs in this population. So everyone who was eligible definitely didn't get it. That wasn't the intent, but we saw about 15% of people enrolled who were likely eligible. And the people who were enrolled, demographically, there were a slightly higher proportion of females, people who were Black and of Hispanic or Latinx ethnicity enrolled in Flex. In terms of service type, 83% were enrolled in nutrition services and 22% in housing, and some overlap in that because some people were enrolled in both types of services. And their most common qualifying health conditions were obesity, depression, anxiety, and hypertension in that order. And this is a figure that just shows you the pace of enrollments, so you can get an idea of how enrollments progressed over time. So these are quarterly new enrollments from the beginning of the program in 2020 through 2023, and you can see that orange line on the top is nutrition services, the blue line on the bottom are housing services. So in both cases, enrollments picked up slowly and then increased a bit in pace over time, particularly for nutrition services, which continued to increase in pace. Now, this doesn't reflect ongoing enrollment, so there were more people than this enrolled in the services. These are just new enrollments. And you can see our numbers in housing services stayed relatively low throughout the pilot. All right, looking at some qualitative data to help understand and contextualize all of this. When we talked to people who were enrolled in nutrition services of Flex, we heard, by and large, people were pretty satisfied with their services. They noted that services helped with having enough food and with eating healthier food. For example, one service recipient said, "It gave me a better taste of vegetables. It made me eat more vegetables than I had before in my life. Like Brussels sprouts, I would never have eaten them if I didn't have them in the box. And so in the long run, my diabetes was much more manageable." So there you see people describing not only changes in their dietary intake, but also improvement in managing a chronic health condition. We also heard about reduced stress. So for example, one recipient said, "It took away a lot of the anxiety I had, the worries, and that helped me." So going beyond just access to food or healthier food, some impact on people's psychosocial status. When we talked to people who were receiving housing services or who were enrolled in housing services, experiences were much more mixed. We did hear a lot of appreciation for the help and guidance, but also frustration with lack of housing availability and very long wait times, which for any of you who work in housing, and as we've just heard, is such a common and complex issue. So for example, one recipient said, "I have somebody helping me, and they said, you can go into affordable housing. But I got a little disappointed. I got the application form, but they told me it's a 4-year waiting list." When we spoke with ACO staff and staff inside the SSOs, we got some really great information about what were the biggest challenges with implementing this program, and things that were reported by both sides, both inside the health system and in the SSOs, were the administrative burden. So screening patients, checking enrollment criteria, actually getting patients enrolled, following up on their services and status, all of that created a huge administrative burden for both sides. Also, there was a lack of standardization in these financial contracts that I mentioned. So we think that Mass Health and the state wanted to allow for a lot of flexibility. And so each ACO was in control of exactly which SSO they partnered with and what that contract looked like and what services they paid for. But what that led to is that every contract was structured totally differently. And so you had some social service organizations who partnered with multiple ACOs and had dramatically different contracts for all of them, which made it really burdensome for them to manage this program overall. So one SSO staff said, for example, we've got now 10 different contracts under the Flex program, but they're all literally different contracts. That's obviously very hard to have things standardized across, to not have things standardized across our contract partners. Things that were reported specifically by the SSOs were really important for us to hear too. So they noted a lot of challenges with sharing data, as has been talked about in some other sessions in this conference. So receiving referrals, following up on them, documenting outcomes. There was often redundancy in effort. So even sometimes where there was a closed loop platform available for use for SSOs, that meant they needed to document outcomes there and in their internal tracking systems. And so there was often 2, if not 3 times duplication of effort for the community organizations. And then there were payment challenges. So the way that payments were structured were sometimes really difficult for community organizations, particularly with delayed reimbursements. And so one staff said one of the challenges we had to get over was the cycle time of invoicing. Because if we don't have money in the account, we can't fund the grocery cards ourselves. We don't have that much working capital. And so whereas it was very normal for the health system to sometimes have a 1 to 3 month lag in paying some of their bills, that was not normal at all in terms of the income that community organizations needed to function operationally, right? And what was reported from within the ACO were often communication challenges with the SSO. So often, breaks in the loop, not getting a closed loop of information about what happened with a particular patient after they referred them. And then really burdensome reporting requirements back to the state. So the state had some significant requirements that within the ACO staff had to spend a lot of time working on. For example, someone said, right now, we have to renew every single enrollment record, and we have 1,000 patients enrolled in Flex services. We were told what to do, but not given any data or tools or resources that would help us do that. Okay, on the positive side, we also heard a lot about implementation facilitators, which I'm really excited to be here and sharing in some of these with other states and programs. Anytime that SSOs had access to or could develop tools to address those data sharing challenges, that was hugely helpful. And one of the ways that happened was that there was state funding in the beginning of this pilot that SSOs could apply for. It was called the SSO Prep Fund, to help them build infrastructure for their participation in these contracts, right? And one staff said the SSO Prep Fund was awarded to SSOs to build out the technology infrastructure to support their expansion into being able to store and share data in a HIPAA-compliant way, something that historically SSOs maybe did not have to do. And that has been an incredible support, they said. In terms of impact, from the perspective of the SSOs and the ACOs, we heard a lot of positive impact. Sorry, I just lost myself on my own slides. There we go. Okay. So yeah, the state funding, the tools to address, and then the last thing, yes, routine ACO, SSO communication. So when that happened, that was hugely important. And you saw one ACO staff commenting, we meet with our community partner monthly, we check in, and there are rarely any issues communicating and getting referrals in. So when there were regular or routine communication, then that supported the program enormously. Now getting to impact, right? So when we talk to people from the health systems and the community organizations, we heard about positive impact of the program on patients. An SSO staff said, I'll continue to sing Flex's praises. What they do for our patients is extremely helpful. From the cookware to grocery cards to high quality produce, it's very beneficial and our patients truly appreciate it. Interesting, we also heard a lot about the positive impact of these contracts or these relationships on the SSOs themselves organizationally. So there was organizational growth and development. By and large, the SSOs were super enthusiastic to be a part of these partnerships, even though there were some challenges. One person said, Flex services and the ACO system are sort of a dream come true for us. Working with ACOs is a way for us to not just demonstrate the healthcare value of what we do, but also develop best practices. However, as I mentioned, there were some ongoing challenges, particularly for the SSOs. The administrative burden remained significant throughout the project. And year to year, there was a lot of uncertainty for budgeting and hiring. So as the state and the health system made adjustments to their program throughout the pilot, those changes were passed down sometimes relatively last minute to the SSOs, and that caused a lot of confusion, frustration, and just organizational difficulty with doing what they do, right? So one person said, when I started, there were 2 staff and I was told to hire, hire, hire. And we got a bunch of people hired. And now I feel as though we finally got to a point where this is great, we're fully staffed, and then we were told about the budget cuts. So you can see how the impact of those changes gets really passed down onto the SSOs. So it's some summary and conclusions. In terms of reach, the Flex program reached about 1 in 6 eligible ACO members who were enrolled, and it reached members that were at high risk for chronic disease disparities, so obviously that's great. In terms of effectiveness or perceived impact that we heard from qualitative data, a lot of our data suggests that nutrition services in particular had positive short-term benefits, but there were some mixed experiences, especially in the realm of housing services. More research is needed to understand any long-term impact that these services may have had. And in terms of adoption and implementation of ACO to SSO or health system to community organization contracts, the ongoing challenges are really the administrative burden of these programs, lack of standardization of contracts, data sharing difficulties, and budget uncertainty. Whereas some facilitators were administrative funding that could help reduce some of that burden or help appropriately staff the programs and help SSOs prepare for these contracts and relationships, and also improving cross-sector communication. So lastly here for some implications for policy and practice. So building on our prior work, we did publish some results of the first year rollout or first year implementation of Flex back in 2023. You can see the citation there. But in addition, now looking at the whole 3-year pilot, or looking at the 3 years as a whole, our study really demonstrated the need for some efforts to standardize those financial contracts, for sensitivity to and better understanding of the impact of payment models on the SSOs, and some common data sharing platforms and communication tools, perhaps in part at least supported by the state, that people could use throughout for these contracts, and administrative funding to build SSO infrastructure for social care, for the linkages in particular. And as always, more research is needed to determine the most effective and cost-effective strategies for these linkages to promote health equity. Here's our research team at Mass General, based in Mass General. And thank you so much.